We have a very special session coming up next. When we designed originally the program, we were really wanted to create a time in which we can go back to basics, start to go back to the message of why we are here and what we are doing here. And in the same times, as you see, a lot of presentation and a lot of papers, scientific papers will be presented. But sometimes we have to understand that there are a lot of bias underneath all of the science that touch everything in cardiothoracic surgery as well as in coronary surgery. So the next 30 minutes, we have two very important speech, 15 minutes each, from the two program directors, co-program directors of these outstanding meetings. And we want to really go deep dive into the biology of coronaries and the deep biology and genetics of coronary research. So let's start with the talk of Torsten Donst from University of Jena, who will talk about how does CABG and PCI work, physiopathological and clinical differences of treating coronary artery disease.
Yeah, thank you, Gianluca. So ladies and gentlemen, that's I told you yesterday to think mechanistically. And I don't know if you've all been to the meeting, to the presentation yesterday, but let's just go through this think mechanistically, and I brought a case. So Mr. Miller, you have triple vessel disease, we need to revascularize you. Okay, so what's the mechanism? Improving blood supply. What the treatment options, PCI or CABG. The patient will hear both treatment options have the same mechanisms because it's both revascularization. And what's the logical choice? What does the patient will choose? PCI. So what is left to operate? And if you look at this, that's the reality. There's a steady decline in CABG here in the US. And there's also a decline in PCI, but that has to do with courage and the fact that there's some evidence-based thinking here in the US. In Germany, this is the case here. You know, they're still ongoing, it's unbelievable. So we have this decrease, and I would argue that the ability to perform PCI, according to the logic that I just explained to you, will result in the fact that the CABG case volume will go down. So that's the reality, okay? So, how about this? Let's reinvent CABG and let's reinvent the treatment of coronary artery disease. So why do you die or suffer from, what do you die or suffer from if you have coronary artery disease? Well, it's ischemia, right? But how exactly does that work? Well, you have inducible ischemia, and we had that yesterday, and that causes symptoms. And then you have acute ischemia, and that causes cell death, infarction, and so on and so forth, right? And we generally say ischemia causes contractile dysfunction. Well, acute ischemia does, right? Myocardial infarction and rhythm disturbances. So I guess you can say in the acute setting, that's one thing, but in the chronic setting, we have this revascularization paradigm. I'm sorry. We say revascularization treats ischemia, ischemic symptoms, you improve contractile function, you prevent MI, and you improve survival. That's the belief that gets us acting. So if you do this, then you've seen this paper, or this figure already several times. You have inducible ischemia, and the mechanism is restoring coronary flow capability because at rest, there's normal flow. There's no limited flow. You have to induce stress in order to show it because it is not there at rest. And then you have ischemia that's ongoing, and whether there's chronic ischemia is another issue. Then it's acute, then the mechanism is reperfusion. Ischemia reperfusion, you all know this. And then there's the risk of infarction. Okay, so for reperfusion, in acute coronary syndrome setting, there are several trials that PCI and CABG and so on actually prolong life. That's no problem. But what about this? Does restoring coronary flow capability also improve life? Well, we've seen this yesterday. Ischemia trial. No impact on survival, impact on symptoms. No impact on survival, right? So there's symptomatic relief with treating inducible ischemia. So now let's see, maybe there is a reperfusion issue involved as well. So which paper or which study could show this? This Stitch trial. Because Stitch trial was reduced ejection fraction. There may be hibernating myocardium. There may be viable myocardium, right? And all that stuff. So you should see an improvement there. So what did Stitch show? Yes, there was a survival advantage. Great. But it didn't correlate with the diagnosis of viability or ischemia, right? And then the Revived trial now showed it, because with PCI, you have patients with reduced ejection fraction. With PCI, you end up having revascularized in patients with documented inducible ischemia. And what is the outcome? You've seen it many times. Nothing. No mortality difference, no difference in rehospitalizations. Revascularization in these patients with inducible ischemia did not affect life expectancy. Now, what about impact on contractile function? And we operate because now the ejection fraction is poor. Now we want this to come back up, right? So here's a registry analysis, and that registry analysis shows that about 60% of patients actually had an improvement in recovery after surgery. 40% did not. Shouldn't they all recover? Or what do the randomized data show? Neither in Stitch nor in Revived was there any change in ejection fraction. So how do you explain the ejection fraction increase in the registry? This is what you do if you give medical therapy to patients with poor ejection fraction. 12 months later, ejection fraction is 10% better. How is that possible? Medical therapy does. And I would argue that in the registry setting, you have patients that either did not get maximal medical therapy before, so we're basically sort of tagging along and claiming the medically induced ejection fraction improvement as a surgical impact, right? And on the other hand, there may actually be some acute ischemia going on if we operate on NSTEMI patients and so on and so forth, and that may be a reperfusion mechanism. But the treatment that we do for chronic coronary syndrome, where we restore coronary flow capability, certainly doesn't change the ejection fraction either. It's frustrating, but that's the way it is, and that's what the data show. The reperfusion is not a mechanism in these patients. So what about infarction? Well, the Stitch trial didn't assess it, but all the other trials did, right? If you have regular ejection fraction and all these syntax and whatever the trials were called, if you put them all together, Stuart Head did this meta-analysis and demonstrated a survival impact. Again, CABG better than PCI, CABG better than whatever medical therapy, and so there's again this survival advantage. So how do you explain this? So that's what we did. We correlated. We basically looked at what is the rate of infarctions and rate of mortality in the stent groups and in the surgical groups. And the less infarctions you would find in the surgical group, the lower your mortality. So less infarctions, better survival, because people still drop dead from heart attacks even today. Okay? So that's what led to this concept where if you put a bypass graft to treat a severe stenosis, you always take care of this. But if you treat only the high-grade flow-limiting stenosis, you cannot address this. And Mario and I actually did this, or Mario did this very nice meta-analysis where we looked at all the trials and all the registry data that are available comparing CABG and PCI. And we found that CABG was better than PCI. Yes, great. That's all known. But interestingly enough, only if there was a difference in spontaneous myocardial infarction here, there was this difference, and that was even consolidated. But if there was no difference, this is the outcome. So if we do not prevent more infarctions than PCI, or do not prevent any infarctions, we're not better than PCI, and we're not impacting survival. That's the conclusion from it. So that's it. So you have inducible ischemia, restoring coronary flow capability. That's a symptomatic relief. But if you prevent infarctions, that improves your survival. And this impact of CABG is so strong that if CABG was a vaccine, and if the same criteria as for a COVID-19 vaccine were sort of set forth by the FDA, you would get approval. This is a really strong stuff, right? So you can use it as a vaccine. But interestingly enough, it's not only for CABG versus PCI, it's also for PCI versus medical therapy. Because that high flow limiting lesion that you stent can cause infarctions occasionally. It'll do so in a much lower grade because 90% of all infarctions come from non-flow limiting lesions. So if you stent, you still have 10% of chance. So if the number is big enough, you see the same thing. If PCI has an impact on mortality, it does so by preventing myocardial infarctions. That's what the data say. All right. So then there is, you've seen Greg Stone yesterday, and he talked about prevent and stenting vulnerable plaques. And this is sort of a surgical take. You can basically analyze this, and then you stent now in order to not stent later. But the other outcomes are irrelevant currently, and it's only one stent and one lesion, and so it's very cumbersome. But the key is there are many trials that, and that's a differ because we keep talking about complete revascularization, okay? And then they say, oh, you need to completely revascularize because the partial revascularization is not good, always implying that it has to do something with flow. So here are three trials, BioVasc, Multistars, and FIRE, that assessed complete revascularization with stent versus culprit lesion only or delay, immediate, complete versus staged or culprit stenting in patients with acute coronary syndrome. So they came with the culprit lesion and then they were either treated completely or partially. So this is the outcome. What is the important outcome? Two of them here had no impact on survival. FIRE in older patients, they were above 75, there was actually a survival advantage. But look at this. The difference in myocardial infarctions, again, was always visible. So how did they generate a treatment effect? By preventing MI, not by revascularization and changing blood flow or anything like that. That doesn't do anything except for taking your symptoms. So you prevent your myocardial infarctions, even with a stent. But the potential is much lower. And so the question is, what about in these trials? What about the most invasive, the most powerful tool to prevent MI? What about CABG? Culprit lesion stenting plus CABG. What is that? That's the concept, if you think along those lines, hybrid procedures, etc. That's what comes in. Because, now the idea of the interventionalist is if we have triple vessel disease, we do complete revascularization because we're better than culprit lesion only, but their control group is missing. We're just being ignored as a surgical community that has the most powerful tool to save lives. So why is CABG feared so much? Well, I guess stroke, sternotomy, mortality, right? So this is our way of doing this here. These are 3 patients from Risto Kirov. You're sitting back there. He did triple bypass on these guys, and they had all no touch, off pump, fully arterial. So there's no stroke and no sternotomy. So what is the risk of surgery? Of course, the stent is much less invasive. Yeah? It's much less dangerous. 30-day mortality is exactly equal. Exactly equal 30-day mortality. So we're more invasive, but we're not more dangerous. And it's the same in risk-adjusted registries, the same thing. So now I'm doing something. Where's David Taggart? David, this is a provocative statement, whatever. So if you can do this, if you can do minimally invasive, fully arterial, no stroke, no sternotomy, why do we need PCI in treatment of chronic coronary syndrome? It's a vague, strong hypothesis, I'd say. I'm just doing it as a joke, but there's something to it. Because stenting causes inflammation. And here you can see if you put a stent 3 months of CRP elevations, there's a chronic inflammatory response. that you generate. And this is also interesting because the fibers, the vulnerable plaques that you have, they appear to be populated with bacteria, a bacterial material. So I don't know whether I would be happy to put a foreign material on top of something where there are bacteria in there, you know? So that's something sort of to think about in this whole mechanism. And from that, I'd say that our revascularization paradigm that we have is certainly not correct. You know, we need to sort of think mechanistically. And I think the problem is this. If you have a non-obstructive coronary artery disease that has this plaque that can rupture any time, right? And some of them, they develop obstructive coronary artery disease, and those are the ones we see. So they are the lucky ones because they develop symptoms. We detect this, and the symptoms may progress, and then they may get an infarction or may not. But those are only the ones that, a small fraction of patients that get this. The vast majority gets this. So if we have the complex ones that have a high risk of myocardial infarctions, the collateral here has the greater potential to do something than the stent that is not able to address the remaining lesions that are responsible for the majority of myocardial infarctions. So with that, let me get back to our Mr. Miller. So how about this? How about we talk to Mr. Miller? We don't talk about revascularization anymore as surgeons. We do it the following way. We say, Mr. Miller, you have triple vessel disease. We have 2 invasive treatment options for you. We can do PCI, it's less invasive, and it takes away your symptoms. Or we can do CABG, that's much more invasive, yes, but it's not more dangerous, it takes away your symptoms, it has the chance to prevent heart attacks, and you probably live longer. What do you want? So guess what happens when you talk to patients like this? There's a surgeon who can tell you in several aspects, all of a sudden, we're not the evil guys anymore. Thank you for your attention.
Fantastic presentation. These one were meant to be keynote speaker. We will see if we have time for some question after, but we want to go for the next talk. And it's a pleasure to introduce Dr. Faisal Bakin from Cleveland Clinic. He will speak about the controversy behind modern coronary trials. Faisal.
Good afternoon. So where's the best place to be? New York? International Coronary Congress? Do you want to be more specific? Well, I can be. Just in the middle between those 2 guys. So again, this is going to be fun. So talking about fun places, this is not a fun place to be, the TCT, because at the last TCT, 2 so-called late-breaking trials were presented, and one of them was the 10-year results of the NOBLE trial, which showed no difference in survival between CABG and PCI, even though the primary endpoint was never about survival. So it wasn't even powered to look at that, yet the presentation was PCI and CABG are equivalent. And the other one is the FAME-3 trial, where they used a quality of life and cost-effectiveness analysis. My head is still spinning, reading the methodology that declared that PCI is more valuable than CABG. Wow. But let's start talking about what's happening in this day and age. Now, it's all going to be scientific facts, but I like to show things visually because we're all surgeons. We're all surgeons. When we look at a trial, when we look at study, when we look at evidence, you got to look at the facts. And you got to look at the context. What kind of population you're dealing with? What kind of intervention? What kind of endpoint? What's the long-term outcomes? Not just the first year, 3rd year, 5th year. And then you begin to see that there's a spin, there's unrealistic assumptions, designs, definitions that somehow picks a winner. And that winner is never CABG, unfortunately. Let's look at trials that looked at CABG versus PCI. I love the Syntax trial. Why? It was a very thoughtful, well-conducted trial. 1,800 patients, 3 vessel and left main disease, 85 countries, reputable, trustworthy investigators, and they adhered to protocols from beginning to end. The trial had the 2 arms, the PCI and CABG, but importantly, they said, what about cases in which there's no equipoise? So they had a registry. So it was more representative of everyday practice because they included everyone. So that's why I love it. And if we look at the registry, 41% of the patients, there was no equipoise, and most of them had CABG. 35% went to CABG and only 6% went to PCI. And when you look at the reasons that CABG was presented, is because CABG was chosen is because they had anatomic complexity, trifurcating left main, diffuse disease, etc., they're really unstentable. But those 6% that had PCI predominantly had higher physiologic risk. They were frail, cirrhosis. So there's an explanation. And that's why I love this trial, because they were honest about what they started with. And they looked at reasonable outcomes, and that is objective variables that indicate outcomes, and that is MACE. And the outcomes were in favor of CABG in every single category except stroke. We don't expect CABG to improve stroke, and all-cause mortality. However, at 10 years, there was a significant advantage to CABG. And that was reflected in the guidelines, even the American guidelines, whereby if you have left main disease, or if you have complex disease plus or minus left main, then CABG is a preferred therapy. And for those of you who don't know, and this is published, Syntax is the most highly cited trial comparing CABG versus PCI. Over 2,100 citations. And the second place is the Salim Youssef meta-analysis at 1,300 plus. So people trust Syntax, and Syntax was well designed, well conducted, and we believe in the results. So what happened post-Syntax? I call it evidence gate, and I'll explain to you why I call it evidence gate in a few seconds. And it started with changing the rules. So we had a set of rules that Syntax stuck to, and now we're changing the rules. And I call it evidence gate because if you read here, the Watergate, it says that politics used to be considered a noble public service until Watergate. And I think until Syntax, we were okay. After that, the evidence gate kicked in. And I'll show you some examples. This is not meant to be personal. I know Bill Fearon is here, and I told him I'll just stick to facts, and he can be here to defend them. But nevertheless, I think there was some changing of the rules here when it came to presenting the follow-up results of the FAME3 trial. The starting point, first of all, the population represented in the FAME3 trial is not reflective of a typical practice. If you look at the STS database and look at the patients that were randomized in FAME3, they're very different. Only 28% in FAME3 were diabetic. If you look at the STS database, it's more like 50%. Then you look at previous PCI. If you look at the STS database, more than a quarter had previous PCI, while only 14% in FAME3 had previous PCIs. If you look at how many patients had a Syntax score that's greater than 32, only 17% in FAME3. So the severity of disease, the comorbidities of the patients were less than the average STS patient. And then, if you look at the immediate outcomes, it was an impressive show for CABG. The 30-day mortality was a 3 in 1,000, identical to that of PCI. Now, when they looked at the primary outcome endpoint, they had non-inferiority margins. Again, I respect that they chose about 30%, 0.3 hazard ratio. But if you look at the actual numbers for the hazard ratio, the risk associated with PCI was 1.5, and it was 1.1 to 2.2, meaning it's greater than 1, meaning that it's statistically favorable towards CABG. However, because they chose non-inferiority margins, the p-value may appear like there's no difference between them, but that no difference, when you translate them to English language, becomes not non-inferior. So double negative means it is inferior, but the way they report it in the conclusion of the New England Journal of Medicine is that it's not non-inferior. So actually CABG is better, but it was presented in a smart way to kind of cover that up. And then when you look at the 3-year results, they decided to change the primary endpoint. Now, yeah, that was a pre-specified secondary endpoint, and they have every right in choosing that, but that should have been immediately available in the abstract, and at least the primary endpoint itself be highlighted in the abstract, because the difference between PCI and CABG was significant at 3 years for the original primary endpoint. Same thing happened for the 5-year results. The primary endpoint is reduced to a line in the table, while the abstract concentrates on the pre-specified secondary endpoint, which is a valid secondary endpoint. I'm not criticizing it. Excluding repeat revascularization may be legitimate, but I'll show you later why it is not entirely not controversial. It's debatable. Excel trial. Dr. David Taggart has a long journey with this trial, and he's written extensively about the violations that took place with the Excel trial. Dr. Mehmet Oz said, you got to have mojo, you got to stand up, you got to point out the deficiencies. Don't be shy, because if your opposition wants to prove you wrong, let them present a scientific counter-argument. This is not emotional, it's about the numbers that I'm showing here. They excluded repeat revascularization from the primary endpoint, and they included patients with less severe coronary artery disease, syntax score of less than 33, and the results were negative. However, what about the difference in all-cause mortality? The New England Journal of Medicine has a rule that if it's the all-cause mortality, even if it's a secondary endpoint, you should bring it front and center, even in the abstract, if it is different between the treatment arms. Well, that rule was ignored because there was a 38% increase in all-cause mortality associated with stenting compared to CABG. And what about the change in definitions of periprocedural MI during the trial? Nobody talked about that. It wasn't mentioned anywhere until Taggart and others had the mojo, had the courage to say, hey guys, wait a second. If we look at the actual definition that was agreed upon, the third universal definition, then the incidence of spontaneous MI was double that in PCI compared to CABG. How come nobody's talking about it? And they forced the New England Journal of Medicine to publish that in a follow-up letter to the editor. So thank you, Dr. Taggart, for standing up for what is right. What about CABG versus medical therapy? I'm not going to spend much time on this because we talked about ischemia earlier today, that it never randomized a single patient to CABG or PCI. The proximal lesion greater than 50%, which is not the 70% customary for significant severe disease, was only present in 36% of patients. So ischemia had rare or medium rare. We just had lunch, so I could show you that slide. Nobody's hungry anymore. But CABG was more like well done. Complete revascularization was totally unrealistic, totally, it was never replicated in any other study to have such a low revascularization rate. Even PCI has a better complete revascularization rate than 35%. That's why we questioned the robustness of the data. And that is why we criticized the guidelines, because we had to do it. Many in this room had the mojo to do it. And congratulations for doing that, for your specialty, but more importantly, for your patients. And the European guidelines listened to the evidence and did what's right. Now, another phase of evidence gate is actually new rules that are totally unvalidated. Not changing the rules, not changing rules. It's actually totally abolishing the rules and coming up with stuff that's unvalidated. When you look at new definitions, when you look at new endpoints, you got to validate them first. The proposition that MACE is no longer important is BS. And that's what was used for syntax: death, stroke, MI, and repeat revascularization. And the editor of New England Journal of Medicine Evidence, Dr. Sachs, indicated that if you're looking at an outcome, that has to reflect the disease process that you're trying to treat. So when we do coronary disease, we're trying to treat atherosclerosis. That's why we look at MACE. It has nothing to do with perception about the quality of my life or whether I'm depressed or happy. Nothing to do with it. So those that are pushing quality of life, which is very important, we should all capture quality of life in our studies, but it should never be the primary endpoint for the reasons that I've outlined here, and I will elaborate on very quickly. MACE is objective, quantifiable, identifiable, and validated, and consequential, because if you have a stroke, you might die. If you have a stroke, you might have residual deficit, and the FDA itself said that objective event captures how people feel, function, and survive, which is really quality of life. MI, Torsten Dorns showed us the study that only on studies that spontaneous MI is reduced is survival enhanced. So actually spontaneous MI does translate into mortality, and repeat vascularization, even though it's being pushed down and downgraded. If you look at the Syntax trial, again, data, repeat revascularization is an independent predictor of death, stroke, and MI. These are facts. So the inconvenient truth to many people not in this room is that CABG is associated with significant reduction in MACE, and the strategic response by some special interest groups is, hey, let's pick an outcome measure that will give other therapies a chance against CABG. Oh, and expect no problems if we say these are novel approaches, novel endpoints, patient-centric. Well, yes, of course, we're all patient-centric. That's why we do medicine. That's why we operate on our patients. So we shouldn't be doing those rule changes and new rules and new definitions just to justify indication creeps, unnecessary therapies, or less effective therapies. We should be very careful. And this is the never CABG symmetry. So you talked about Mr. Miller, Torsten. I'm going to talk about Mr. Wally, who died of a heart attack at the age of 65. And his friend is asking, so how is your quality of life? Well, I'll tell you the answer in a few seconds. Now, remember, Syntax did look at the quality of life. It's not a novel endpoint. However, there was greater relief of angina after CABG than after PCI at 6 to 12 months, although the extent of benefit was small. Everybody loved that. Well, now we can grab an endpoint where the difference is really small and show that there's no statistical difference, therefore PCI and CABG are equivalent. Don't let them do that. Because what is quality of life? It depends who you ask. What is the best way to measure it? Nobody really knows. And when do you measure it? 1 month, 6 months, 1 year, 10 years? Good day, bad day, sometimes, all the time? So this is what Wally's saying. So in summary, MACE outcomes are objective, consequential, and immune to manipulation. Other measures are very useful, but they have to be validated and measured in addition to objective MACE. In conclusion, we all want robust coronary trials to guide the way we treat our patients. We need the surgeons to be alert and to be at the table and be involved in those trials. And we should support robust trials. We should speak out against things when they're wrong. And more importantly, it's time to shift and focus on studies that actually genuinely improve the revascularization modalities and prevent coronary artery disease altogether. Thank you very much.
Fantastic. Sit here with us, and we have time for very few questions. We are already 8 minutes above our time, but we cannot let a session like this go without a little bit of debate. So we have a treatment that is excellent for a pathology that provide long-term quality data, but we have a problem. Houston, we have a problem. And the problem is that somehow in the last 10 years, when we compare against PCI in most of the trial, we tend to lose this capability of showing the benefit of what we do. Guys, how do we change this? How can we somehow impact? How we stand up for it? How can we really make a difference? How can we make sure that our patients get the right treatment? Faisal, I ask you this question for you first.
I mean, I have coronary disease in my family, and I showed my father's cath. If they come up with a therapy that actually effectively reverses atherosclerosis, I'll be the first one to throw the knife down. But my father is only alive because he had CABG. And we looked at the Cleveland Clinic database, and we found out that there's 167 patients that have their native circulation totally occluded, ostial left main or left main equivalent, and the right side totally down, yet those patients are alive. And as a condition to be alive, they all had a CABG. Precisely what Torsten had showed us, that CABG protected you from today's lesion and future lesions. However, if we can find ways to improve on that, drop the CABG. We'll do something else. We'll do valves, we'll do TAVRs, whatever you want.
Torsten.
I fully agree. I think that we have a problem that is based on historical developments. Cardiac surgery has developed at a time when there was no alternative. Patients were there in abundance, and everybody was growing over the years. And it's not, I mean, why didn't we do scientific evaluations of what we needed? It was not necessary. Where there was no need to do a trial to show what we did because everybody wanted it, the demand was so high. So now we are in a situation where we have more and more alternatives. Whether they are better or not, we don't know. We know that we have the best long-term outcome so far, but we have not learned how to defend in scientific terms, like you defend your thesis project or so, right? We have not learned how to defend what we do every day. That is the problem, and that's what we need to learn, and that's why I say we need to step up academically or we step out of the operating room. Yeah. Because we have the better tools, and we have the better long-term outcomes, but that's it, then we don't.
And you showed the slide of those 3 patients that are having minimally invasive CABG. And I like minimally invasive CABG. However, if you spread the ribs and you look at the MIST trial, I don't believe it's been published, but it was presented at the AATS, the difference between the length of stay of a sternotomy and a thoracotomy, meaning thoracotomy, were just hours. Now, what's incrementally different is something that has not been scaled yet, and that is what Gianluca and what Sam does, where there's absolutely no spreading of the ribs, and the patient can leave the hospital the same day or the next day. If we can democratize that, then nobody can even think about PCI in those situations, because I'd rather have this minimally invasive therapy through ports without rib spreading and be home the next day, and not only get the results at 1 year and 3 years and 5 years. I want to get them at 30 years like my dad.
I add 2 things in the same context. First of all, the game is this one, guys. For too long, I think a cardiothoracic surgeon has not been involved enough in research. We need to have someone standing on our side for big trials, be there, and that takes time, guys. There is no way we can have someone busy clinically and being able to sit at this conference, sit at the Zoom meeting and see. We need someone that represents surgery appropriately and defends surgery appropriately, number 1. Number 2, we need more cooperation. I mean, I can tell you every time I submit a paper about a TCAB or a robotic CABG, I get this fire back that is crazy from colleagues, from us, from people like you guys. These reviewers are, I don't know, what did they hate?
Oh, guys, be nice to Gianluca.
Be nice to me, guys.
Be nice.
No, but what I'm saying is like, and then you see the PCI room for a CTO PCI that carry 3% mortality risk, full of people and everybody supporting each other, everybody congratulated to each other. So we need to stay a little bit more close together. We are a community of people that are always finger the points. Oh, you use radial? Oh my God, you use on pump? Oh boy, off pump only. Robo, please don't talk about robotic. Or we need to stick a little bit more supporting each other. I'm not against thoracotomy. I'm not against on pump. I do different things, but let's stay together, guys. We are caring for patients in a very different way than PCI, and this message should be loud and clear from all of us. Yeah, please.
Yeah, just a quick comment. A thought that has been coming to my mind throughout this meeting is we need more patient representation in our guidelines, because they're the people who will probably defend best their interests, and having that representation might really help people to be more fair and to make sure that we are choosing
Well,
appropriate guidelines.
I can sort of speak to that because I've been in the European chronic coronary syndrome guideline, and there were patients there. There was one bypass patient and one stent patient, and they were both convinced that what they had were the best.
Yeah.
So it's very difficult because you cannot, if you get a stent and you live 1.5 years shorter, you don't realize that. It's very difficult on the individual level, And so that's why, and the cardiologists in Germany, they tell us that the patients don't really care about their longevity and their life expectancy. Well, I have a completely different experience when I talk to them. So I think that the most important part for us is that we communicate in a way that the patients understand it. And as long as we agree to call what we do revascularization, we shoot ourselves in the foot. And I showed you the 2 slides that demonstrated that. And I have had a tendon torn, and I had surgery, and I had my arm 8 weeks in a sling. So 8 weeks, so big deal. Now I'm back, I'm 100% back, I can do pull-ups, I did it in the gym this morning, and everything is fine again. Do I care about the incision? Do I care about 8 weeks of investment? I don't. I want my functionality back, and I want to do it as long as it gets. And that's where, the most powerful technique has to be able to stand up and say this. Yeah. And we have sort of allowed our opponents to tell everyone that a sternotomy is evil. There's nothing wrong with a sternotomy if it delivers the impact that it does. Exactly. And the quality of, that's why, the fight that we have among each other. So is he delivering a better outcome with his TCAP than when I do sternotomy?
Of course.
Of course he is.
Torsten,
No, but
are you one of the reviewers?
No.
He is the reviewer. Now I do.
That's right. No, what I'm saying is the argumentation among us. Of course, it's better. But when I was a fellow with Tyrone David in Toronto, and he told me when I went into this minimally invasive business, he said, "Do not compromise quality on site for incision." And that's something that is very important. So however you do it right. That's the thing, because that is our greatest trump card that we have. We have excellent long-term outcomes. And if you mess it up, the outcome, because you cannot or are not able to generate it through a small incision, then don't use sternotomy.
Yeah, we have thank you. And tomorrow we have a session with patients, so please don't miss it. We have patients after sternotomy capture. Please, 2 questions very quickly. We have 12 minutes after, please.
The is a comment. I agree with Dr. Dunst says. It's not the matter how to do the operation. You can do on pump, you can do off pump, you do sternotomy. You do the most important things. If you want to win from the cardiologist, you have to put arteries, because we have a lot of literature saying us on long-term arterial vascularization are better than a lima vena.
Yeah.
That's the secret. Not how you do the operation. Put arterial.
Very good. Great message. Please.
Very quick comment. We are succumbing to ourselves, actually, because we are trying to match the cardiologists on their same level, which is level of invasiveness. And this has been a huge mistake. And I'm performing TAVI myself, and by 10 o'clock in the morning, I'm discharging the 3rd patient with aortic valve replacements. It is impossible to challenge this on the same level. We do not have to fear to say that full revascularization, even through sternotomy, while we pursue a way to do it minimally invasively, is still the best option. We are trying to be in disguise. No, but I can do something less invasive for you as well. Don't go to the cardiologist. No, we don't have to lower our level. The evidence is there to say that survival is what matters. As if survival takes sternotomy, then we go sternotomy. We don't have to fear that.
Thank you. Last comment, very quickly. We have
just a comment. Thank you for the presentations. I think the most important difference between PCI and CABG is to bring well, healthy, prepared artery, internal mammary, that is very rich in nitric oxide supplied to the coronary circulation. It is not just opening a pipe which is stenosed or diseased. PCI will open the pipe that is already diseased and closed, but will not bring more nitric oxide to the coronary circulation.
Very good.
I think this is the cornerstone to start with indifference between PCI or CABG. And we know all the effects of nitric oxide on the coronary circulation regarding vasodilatation, preventing more progression of the atherosclerosis, thrombosis, and more and more. Thank you.
Thank you so much. Thank you.